So today we are at Terumo Skill Lab, and Terumo has just received a beating heart model, which is possibly the second or third in the world. And the beating heart model will help us demonstrate how difficult or how easy angioplasty is in a beating heart. We hopefully be able to record the proceedings and show how the procedure goes. All these years we have been working on static models, especially in the bifurcation club meetings that we conduct in Mumbai every year. Terumo has been kind enough to associate with us, and they were static models. We are longing to have this beating heart model. Beating heart model helps us to understand the intricacies of the influence of a cardiac cycle of moving heart on bifurcation angioplasty, and hopefully we should be able to show you how good it is. We would discuss the model drawn here. Now, this is a typical lesion shown here as a left main bifurcation lesion. So this is a Madina 1-1-1 classification where the main vessel is diseased, the side branch, the LAD is the side branch, and the main branch is the circumflex is also diseased. Okay. What we did today was a decay crush. What we did today was we demonstrated a decay crush technique on a beating heart, which was a unique experience. So what we did was we first wired the side branch, then we wired the main branch, we balloon dilated the lesion in the side branch, then deployed a stent. After deploying the side branch stent, we optimize this side branch stent deployment with a NC balloon. Stent gets well opposed at the ostium side branch, so the ostium is always larger than the side branch as it goes upwards. The ostium is never circular. The ostium is always oval or any other non-circular shape. So here you see the side branch ostium, and the stent proximal to the ostium is little flared compared to the side branch stent upwards beyond the ostium. So we optimize this deployment with a 3 meter NC balloon, and that is what is the new step that has been described: proximal side branch optimization. When we crush this stent with a balloon, we remove the wire, and then we pull back the wire like this, and then the wire just flopped in from here, from the distal most tract. Okay, so the wire went in. Okay, so it's a very critical step when you are wiring across a crush segment. On this wire we passed balloon, we opened the strut, and then got wider and wider, and then so once you got this good ostial opening of the stent following passage of the wire through the crush stent, then we did the first kissing. So then the main vessel stent comes in. Okay, and when you deploy the main vessel stent, you may or may not remove the side branch wire. In our case, we kept the side branch wire and gradually, carefully removed it. The main branch wire is already in position, and do a final kissing balloon dilatation. So once you do the second kiss or the final kiss, then time has come to do the pot. What pot does is, when you have two balloons, when you do kissing balloon with two balloons, Your proximal segment is never circular because two balloons together are never circular, they are elliptical. So this is elliptical, this should be circular. So to achieve this, we do a POT. Okay. So what we do is we took a small 6 mm balloon here, 4 by 6, just short of the carina, the marker just before the carina, and with the shoulder of the balloon just proximal, and this was POT. So you have a good deployment, well preserved carina. Most important is what is here. Carina, we have well formed carina with very small crush segment, good deployment. So that is the decay crush technique. It's a little tricky technique. I can't say difficult, but the game of patience for a beginner or newcomer or interventionist who just started doing it. But as you get a hang of it, I think it's the most sought out technique for large vessels. I won't recommend this for small vessels. Anything beyond 2.5 or less, I won't recommend this. So the main branch and the main vessel and a large side branch, anything beyond 3, 2.75 or 3, this can be the technique. One what tip I would like to give here is avoid long stents. When you're doing a decay crush, try to keep the stent length as short as possible. Thank you. Okay. ठीक है चलो. So the wiring is in place. Perfect. So we are in the branch. Okay, we are in the branch, and now, okay, we need another balloon to be kept in the LED. We'll need a 3 mm NC balloon, 3 mm AccuForce. And a 3.5 mm AccuForce, both. See, a lot of people, a lot of operators want to have a micro crush. So I don't believe in micro crush. There should be at least 2 crowns, 2 or maybe 2.5 crowns or 3 crowns in the main vessel that are crushed, so that you get a good opening for the side branch wiring, get a clear ostium for the side branch wiring. Otherwise, if you have micro crush, sometimes this entire metal can get clumped on the ostium original, then the wiring becomes difficult. So you should have a clean 2 crowns. That doesn't add to the restenosis. This is a 12 mm stent. This is a 3 by 12. So we have about 3 crowns here. We have about 3 crowns into the main vessel. So for the side branch optimization, the balloon should always be NC, non-compliant, so that the side branch is optimized, the ostial deployment is optimized at good pressure. Okay. So I think what we need is we need a larger balloon, because see, the crush is not enough. The crushed part should hit the roof of the vessel. Okay.
Go up to 20.
See, we have crossed close to the carina. So now we have inflated the side branch stent with a 3 mm balloon, and now you can nicely see the ostium is well flared, and now we are ready for the first kiss of the decay crush. Okay, decay crush is a double kissing technique. So now we are ready for the first kiss. Okay, so we need a 3.5 balloon for the main vessel. Yeah, so your side branch is actually 3, and that is, you see how well it is flared. The carina also is, the metal is just at the carina. So when you put a second stent, I think the carina will be having minimal metal. So minimal metal load at the carina is the objective. We will have 2 balloons in place now, so that we are ready for the first kiss. So most of the hard work is before the first kiss, so that how do you open the strut, how do you go through the crush stent, and how do you optimize the strut opening at the ostium, and how do you and then comes the first kiss. Yeah, 10. So optimal, these are NC balloons, so optimal pressure is 12. Okay, so we go to 12 slowly by this. Okay, so this is how the side branch stent deployment is optimized. And the crush stent, now you will see the crush stent is further pushed towards the upper edge of the vessel, upper roof, or the upper margin, so that when you put the main stent, there is no, the pathway is very clear. Nothing protrudes in the main vessel when you put the main stent. Yeah, so deflate. Okay. Okay, so I need a 4 mm balloon to optimize the proximal part of the So your carina is clean and the cells move away, and now wiring the side branch will be easier. Okay, you recorded this? This is the most important, this is a very key thing. Yeah. So we have crisscrossed the wires. The wire from the diagonal we have come to the LED, and the LED wire we have crossed through the stent into diagonal. So now we need a 3 balloon. So this is the final kissing balloon, the second kiss to optimize the result at the bifurcation. So it also optimizes side branch austere and proximal dimensions. Your main branch is already optimized when we deployed at about 14 atmospheres. We did a pot on the main branch with a 4 mm balloon, and we'll do a final pot with a 4/6. Okay, so our procedure is complete. The proximal deployment, okay, we go a little beyond so this is perfect. We go a little more beyond, so that the go. No, deflate. No, good. Go. Yes. So this is a perfect deployment with the marker at the carina, so that your the entire disposition of both the stents should be with the outlook that the carina should be metal free. Carina should have middle metal. So because if you clump the metal at carina, so then chance of recurrence reached to the ISR. So now this is what you see, that the marker is just at the carina and the shoulder of the balloon is beyond the carina, so that you have full expansion just prior to the carina. So your side branch ostium is again okay. So that's how it is. So I think the procedure is complete.
Yes.
Forget.
I am Dr. Subhanan Rai. I am practicing by cardiology and intervention cardiology for maybe 20 years plus, and I am a very close observer and as well as I'm very fond of doing bifurcation stenosis for a long time. We started with provisional stenting in the year 1999, and I presented my first case in CSI West Bengal branch, and thereon I am in the process, and I have working on bifurcation, and we have published our paper on provisional stenting in Indian Heart Journal in 2008. We have published our data on nanocrush, which is innovated by us. Is a double stent technique, and and 2 international publications we have on nanocrush. So, what in this 20 years time, what I have seen, that a training is essential for every interventional cardiologist to do a perfectly a bifurcation stenosis. Be it provisional stenting, be it 2 stent techniques, where a perfect training is required, and very small things, even in the bench test we have seen that very small things develop later, like proximal optimization technique, where to put the balloon, what would be the size of balloon. These are all important, and they came from the training on bench models. So Terumo has come with a simulation based model, and I have had an experience of this model before, and I conducted workshops on these models, and they are good, and they can show you something, but you do not have the feel of doing something on a live heart. And here in this in this model, it is unique to show that it is it is almost like a normal heart beating, and you can put your stents, and the stent can be moved out during systole and diastole. It can move out a lot during the pulsation of the heart, and all these things which are which you get in live heart, and you get the feel in this model. So it is a unique platform for teaching as well as learning. And I would also foresee that in the future probably there will be some flow in it which will be synchronized with the systole and diastole to give it a more live feeling during the teaching sessions. And it is just a beginning of the horizon. It is just the beginning of a new era, and perhaps in the near future this type of simulation based technology will replace all the drawings, books, and it would be a part and parcel of workshops and learning and teaching process in the percutaneous intervention and other techniques. So it is a welcome technique by Terumo, and I thank them for having it. One of the 3 models available in the world. One is in India. It is a great thing to us, and it will help the future cardiologists and future interventional cardiologists to grow up and learn the technique perfectly. Thank you.
Hello, everybody. This is about a unique perspective on bifurcation angioplasty. That is our brief today. And we're going to discuss the decay crush technique, or rather, how it has come into being and why it has become so favored in this part of the world. Now, decay crush is a technique which is shown itself to be superior to the available techniques at that time, especially specifically the provisional technique. Decay crush is a technique that looks at complex bifurcations with 111. It can be applied to all anatomies of bifurcation almost. It can be applied regardless of the size of the proximal mother vessel, the distal mother vessel, and the daughter vessel. It can be used in various conditions. These are the advantages of decay crush, and it has been shown in a comparative randomized trial to have an excellent 5-year outcome to the extent that the revascular target vessel revascularization rates was around 10% at 5 years, which matches anything that any other technique and actually exceeds any other technique can perform. But there are certain downsides to decay crush. It has got 17 different steps, 10 major and 7 minor, and none of these steps can be bypassed or shortcuts if one wants a perfect result. It also has very powerful opponents because there are lots of experienced and senior operators whose opinion it is impossible to ignore, who feel that there are other techniques which are just as good, and in fact they're very very powerful proponents. It also requires a lot of hardware if one has to do the technique perfectly. It also requires one to be sufficiently experienced in the technique so that one doesn't get stuck in any of the major or the minor steps. That's as far as the theory is concerned. There is a new beating heart model which has been brought in by one of the companies, and that is an excellent learning stage because it allows the operator to have a look at all the different steps and to see actually what is happening when the decay crush is performed, and to see what all can possibly go wrong, and to see how to prevent this from going wrong because of the amount of metal that we are going to place in the coronary arteries, and the way in which we do it is very key to the kind of short term and long term results that we come to expect from this technique, because for it to come to its full potential it needs to be done absolutely perfectly. The major steps involve wiring both the main branch and the side branch, pre-dilating both, placing a stent in the side branch so that at least 3 millimeters protrudes from the side branch into the main branch, crushing the stent with a main branch balloon that is sized sufficiently to the distal main branch. Thereafter, the side branch crush stent is rewired, and a kiss is performed, which is known as the first kiss after the first crush. A second stent is placed from the main branch into the distal main branch. After its deployment, a proximal optimization is performed so that the proximal part of the main branch is sufficiently optimized with the stent. The side branch is recrossed, and then a kiss is performed and a repot is performed for the proximal part of the main branch stent. Now, as one can imagine, there are a lot of possible problems in this. The proper landing zones must be selected for the side branch. The recrossing is always a little bit of an issue in the hands of inexperienced, but after one performs the first kiss, usually there is no problem in recrossing again. All these steps can easily be seen on the model which has been shown, and this is an excellent initiative and will go a long way towards teaching our young cardiologists about the advantages and the disadvantages and the problems, how to prevent these problems from occurring with the decay crush technique. I think that's it, and thank you for the opportunity.